Hello, class. We're going to pick up where we left off. We were on slide number 10 talking about CPTSD, and we didn't get to the last point. The last point here refers to research by Ter in 1991 that argues that a single blow trauma tends to have a less devastating effect generally than people who experience recurrent trauma. We mention this because this is going to lend a lot more support, I think, down the road for the inclusion of CPTSD into the DSM because people are more likely to suffer from ongoing long-term problems of a PTSD nature when they have susceptibility to recurrent abuse, recurrent trauma, and things like that. So that's just another area of support for the inclusion of CPTSD in subsequent editions of the DSM. Looking at the neurobiology of PTSD, there's a lot of evidence that severe childhood stress causes an increased need for attachment and protection, even from the abuser. Is one of the interesting paradoxes of having gone through some experience of trauma is that oftentimes victims or sufferers will want to revisit the trauma in some way, so that it's not just the case that when they're being symptomatic that they're having unwanted interruptions into their normal daily consciousness. But there's something psychological that seems to draw them back to that, which was originally traumatizing. This is called a repetition compulsion. Sometimes this even takes the form of someone who's been the victim of abuse wanting to go back to the abuser. It's also associated with inadequate attachment and bonding, acting out, self-injurious behaviors, emotional dysregulation, and aggressive behaviors, especially in cases where there has been profound neglect. We also know there is a higher level of corticotropic releasing factor, CRF, which is a stress neuropeptide, and atrophy of the hippocampus. Now, when you see atrophy of the hippocampus is a limbic system structure that is famously responsible for the formation of new long-term memories. And so it appears that this kind of trauma can have an impairment in the area of memory formation. This could be some of the reasons why sometimes people fail to learn from their mistakes when they've experienced trauma, and they might not have as much insight into their future decisions. Prozac has been shown to decrease flashbacks, avoidance behavior, and numbing. So some people who are suffering from PTSD can respond well to Prozac. And I skipped this point here. Decreased levels of norepinephrine can often lead to hyperarousal in some sufferers. So that's another neurobiological factor to look at. You'll also see acute elevations in glutamate and in cortisol. Remember, when we're talking about higher levels of cortisol, cortisol is very unhelpful for long-term secretion of cortisol is not very healthy at all. It can lead to compromised immune system functioning and can lead to weight gain as well, which is, of course, going to increase your risk for other health-related factors, including coronary artery disease. We also know that with the neurobiology of PTSD that it does tend to have kindling effects. Kindling effects just means kind of like when you hear about when you're building a fire and you put kindling in the fire area, that it makes it easier for the fire to light. The kindling effects of PTSD suggest that once you've had exposure to some sort of trauma, it can be easier for you to succumb to future experiences of trauma, and that you'll develop a PTSD-like response more likely. Sorry about the cat noise in the background if you can hear that. That's our cat. You'll also see a similar response in people who have heat stroke. It's kind of a parallel example. Someone who's experienced heat stroke is at increased risk for having another heat stroke down the road. Slide number 12. Treatment for PTSD. This is another area that, kind of like with the personality disorders that we'll be talking about pretty soon, where therapy tends to work really, really well. Getting people who have PTSD into therapy is essential, especially getting them into groups. Group therapy can be very effective for people who experience PTSD because they can form strong attachments in those groups, and they sometimes can learn coping skills, and they sometimes speak a language that they often share with each other, and it's easier to build trust oftentimes when there have been other people who've suffered from trauma. So, not just individual therapy, but group therapy can be very effective. The goal for people who have PTSD is to allow the patient to regain control of their day to day life and not live in fear that they're going to have a recurring episode of a flashback or some sort of interruption in their daily functioning because of lingering effects of trauma. Um, Learning how to face painful realities with some degree of mastery, so that it's not the case that you might not ever have some sort of a flashback or an interruption, but that you can take increased responsibility and control over your life, and so that it doesn't tend to rule your life as much as you may have been afraid that it might have. Treatment does tend to take a long time for people with PTSD. On average, successful treatment for sufferers of PTSD resolves in about 9 to 12 months on average. Remember that medication is not a primary treatment for PTSD, so along with personality disorders, it's important to remember that therapy is the treatment of choice primarily for people with PTSD. Beware especially PTSD sufferers who are taking benzodiazepine drugs or other central nervous system depressants. We've already talked about alcohol risk as well for people with PTSD. Um, they're just at increased risk, and that can make their treatment for therapy not go as well. It can compromise their therapeutic course. Benzodiazepines can increase dissociation, and it is overall associated with poor outcomes for people in recovery from PTSD. The author of your text, Preston, says that treating symptoms with meds only um, can can be helpful when the person is having symptoms that are pretty severe, or when they feel like they need to maybe have that medication on hand to be able to ward off a traumatizing attack. And the focus here should be short term, um, meaning that if someone might be going through a temporary depressive episode or maybe increasingly susceptible to panic attacks, maybe it can help to have some medications on hand to help stymie that or ward that off. But just remember that long term, taking these kinds of medications is not an effective strategy, at least as compared to therapy. Another treatment you may have heard about is EMDR, which stands for eye movement desensitization and reprocessing. This is a treatment that has gotten a lot of attention because it appears to be a very new and very inventive intervention for the treatment of PTSD. The main thing I want you to know about this is that it's actually not as new as people have been arguing. It's just another form of exposure therapy, which has been um, the leading category of therapeutic interventions for people who are suffering from um, things like anxiety, obsessive compulsive disorder, phobias, and PTSD. So the main thing to remember with EMDR is that even though it's very technique heavy and you receive specialized training in it, the mechanism behind the effectiveness of EMDR, when it is effective, is that it is an exposure therapy um, designed to increase the feelings of immediacy that can sometimes happen when a person is triggered by something that's traumatic. Um, so again, EMDR stands for eye movement desensitization and reprocessing. The results have been pretty promising. It does remain somewhat controversial because some people think that the results that you get from EMDR are not the result of actually having done a lot of therapeutic work. Other people say no, that it can be very effective because you're not introducing something that's a gimmick. You're actually exposing the person to something that is trauma inducing, but you're trying to encourage them to cope in the wake of that trauma by learning to focus on something else. And in this case, with EMDR, the patient follows a moving light or a moving finger or a moving object or whatever it is that you might have handy back and forth with their eyes. And while they do that, they're focusing on a traumatic image or a traumatic memory. The assumption is that when you track this object while simultaneously focusing on the traumatic image, it will cause the patients to distance themselves from the feelings of horror that they at one time had experienced. So, for a lot of people who've been through something very traumatizing, EMDR can be a very effective treatment. The main thing that you need to remember, though, is that there's nothing inherently magical or special about EMDR. What makes it work is that it's an exposure therapy, and exposure therapies are much more likely to work when it comes to remediating symptoms of anxiety. We're now going to shift over to talking about personality disorders. The first one we'll talk about, and this is the one that will receive most of our attention here for these next few slides, is borderline personality disorder. As you know, there are 10 personality disorders in the DSM-5, and there have been 10 personality disorders in the last couple of iterations of the DSM. It won't be worth it to go through each one of these because really the personality disorders have not received a lot of attention, at least in terms of medical interventions. But we will try to talk about a few of them here. Borderline personality disorder is one of the most common personality disorders. It's not the most common, but it is one of the most common. Relatively recently developed in terms of its name and in terms of it trying to understand the clusters of symptoms that borderline sufferers experience. It didn't really start to get talked about on a widespread basis until the 1960s and 70s. It typically refers to a catch-all category for patients with severe levels of character pathology. Remember, when we're talking about personality disorders, we're talking about people who have symptoms that last several years, that results in highly dissatisfying and often very troubled relationships. Usually there's a lack of relational closeness for people with personality disorders. One person in my past who was a professor of mine and a very good teacher told me that you diagnose personality disorders with your gut more than with your head, meaning that if you are relating to someone for any period of time and you talk with them and you spend time with them and hang out with them, and at the end of hanging out with them you may feel like something's not quite right, that you feel kind of used or drained or exhausted or just something doesn't feel right in your stomach. That's how you know you're probably dealing with a personality disorder. Personality disorders are characterological in nature, meaning that they tend to be pretty deeply entrenched and they tend to be part of a person's symptomatic profile for many years. As a reminder, you need to be at least 18 years of age to be diagnosed with a personality disorder. People with borderline personality disorder often suffer from comorbid symptoms of depression, and they're also very prone to drug abuse. I should probably add that they're also very prone to overeating and engaging in behaviors that psychologically and emotionally fill the chronic levels of emptiness that they often feel. The essential feature of borderline personality disorder is long-standing character instability. People with borderline often feel very empty inside. They feel very inconsistent. They might have mood swings. They might feel on top of the world one minute, then the next minute they might feel suicidal. They tend to have a history of very stormy, chaotic, and rushed relationships. They have chronic feelings of emptiness and impulsive filling. That's why you have to look out for drug abuse and disordered eating. Moodiness, acting out, very low levels of frustration tolerance. The next point here, towards the bottom, can be a little bit scary for people who are treating borderline patients. They often engage in boundary violations, and sometimes they can engage in manipulative behaviors such as suicidality. Borderline patients have a high rate, relatively speaking, of suicide threats, gestures, and attempts compared to actual completed suicides. So their suicides are thought to be more cries for help and maybe a little bit manipulative. The main thing in dealing with borderline patients is that they're just trying to feel a feeling of love deep inside of them that they feel is empty. They want to know who they are, but they oftentimes don't know who they are. And so that's one of the chronic feelings they experience. Through research, there are 3 subtypes of borderline personality disorder that are not talked about in the DSM, incidentally. They are the hysteroid dysphoric type, which refers to a person who is very emotionally labile. Labile just refers to a person whose emotional expressions and moods often wax and wane very dramatically. So when a person might feel on top of the world one moment and feeling very dejected and despondent the next minute. That's referred to as labile. These people are often very sensitive to abandonment. They can be very clingy, and they can be very depressive. The second type is the schizotypal, which is when they're presenting as being odd, esoteric, engaging in magical thinking, depersonalization, and derealization. Now, those are some terms you may not be familiar with there. Esoteric just refers to being kind of secretive or mysterious. That often happens when people develop a language that only they understand, or maybe they and a select group of friends understand. So for the schizotypal subtype, you're dealing with people who often behave in ways that are kind of mysterious and hard to explain. And the third is the angry impulsive type. For people with borderline who are angry and impulsive, they often can be very hostile. They can engage in aggressive interactions and have aggressive interaction patterns, and have often stormy relationships. Skipping down to the next slide here, slide number 16. When we're looking at the causes of personality disorders, the psychological theories tend to predominate, and biological theories tend to be lacking. There are some possibilities that have been floated, but again, as I said in the other video, that when we're talking about personality disorders, we're really talking about the world of the psychologist and the world of the therapist, and the treatment, and the primary treatment for these disorders is long-term psychotherapy. One could be that people with abnormal temperaments could be at increased risk for developing personality disorders. An inability to internalize nurturance or early exposure to trauma could lead to a PTSD-like and therefore very inconsistent attachment style. And so that is specifically referring to the borderline personality disorder etiology. The treatment for personality disorders, like we said, therapy is the treatment of choice. If meds are going to be used, they're usually thought to just target symptoms that may flare up every once in a while. If a person, for example, has comorbid depression or could sometimes have thought patterns that tend towards depression, it's thought that antidepressants such as SSRIs could be helpful. Again, it's not the treatment of choice. MAO inhibitors tend to be good for managing the more impulsive behaviors that some people have with personality disorders. That would especially be the case in people with borderline and with histrionic personality disorders. Remember that benzodiazepines can sometimes be good for people who need them maybe in an emergency, but again, then you're dealing with the downside of potential addiction and sometimes decreased disinhibition. Anticonvulsants can sometimes be good for a person's overall level of health, especially if they may be prone to some bipolar tendencies, which sometimes can be, some people with borderline personality disorder actually present as being bipolar, especially the form of bipolar disorder where a person can have a mixed episode and not be purely depressed or purely manic. They can sometimes have a mixed episode. Treatment is sometimes contraindicated, however, because benzodiazepines can lead to addiction, poor impulse control, and increased feelings of suicidality. Bupropion, which is Wellbutrin, can lead to psychosis in some pre-psychotic patients, so you have to monitor dosage levels really closely. And of course, watch out for drug toxicity when you're looking at this, because people with personality disorder sometimes have higher levels of suicidal gestures or suicidal threats. And sometimes they can use the medication to be self-injurious or to threaten self-injurious behavior. So that also has to be closely monitored, just like with bipolar disorder. Taking a look at other personality disorders, for paranoid personality disorder, benzodiazepines are thought to be somewhat helpful, as well as low-dose antipsychotics. Pimozide for paranoid ideation. For schizoid personality disorder, it's thought low-dose antipsychotics antidepressants, stimulants, and some benzodiazepines for anxiety. What you really want to watch out for here, especially with stimulants for the schizoid patient, is the possibility that their levels of dopamine could be increased, which could increase some of the psychotic symptoms that schizoid patients sometimes exhibit. But that's usually more often exhibited in schizotypal rather than schizoid personality disorder. As a reminder, the schizoid personality is the person who tends to be very reclusive, very shy, and usually avoidant of close relationships with other people. The schizotypal personality disorder, that's where you really don't want to give stimulants to them because that could increase their dopamine levels. They often respond well to low dose antipsychotics, and sometimes they respond well to antidepressants when they're having comorbid mood problems. Again, schizotypal personality disorder, as you probably remember from your psychopathology class, is a personality disorder where a person has a very odd, eccentric, or bizarre way of behaving to people with people that often results in a lack of depth or quality in relationships, and they often are very ill at ease and uncomfortable in interpersonal relationships. Moving on to the histrionic personality disorder, antidepressants and benzodiazepines tend to work very well. You have to watch out for high degrees of impulsivity, however, with histrionic patients because they do tend to be very impulsive. Narcissists can sometimes be treated effectively with lithium. Avoidant personality disorder, which is the most common personality disorder, by the way, the borderline personality disorder is the second most common, is taking a beta adrenergic receptor antagonist, such as a beta blocker. These can be helpful in managing autonomic hyperactivity. For the antisocial personality disorder, drugs are typically not effective at all, and so that's one thing to be aware of. Sometimes antisocial patients do receive drugs while they are incarcerated. A very high percentage of antisocial patients do become incarcerated, and they will take drugs in jail, but they do not tend to have an effect on their antisocial symptoms. For obsessive compulsive personality disorder, Klonopin, which is a benzodiazepine, can sometimes be effective, and clomipramine can sometimes work well taken at a 60 to 80 degree milligram daily dosage range. And in severe cases of OCPD, Seroquel, which is a second generation antipsychotic, often works well additionally.